Thank you, Rich. It really is a great honor to be here in Pittsburgh. It is my first time, and you do have a lot of bridges. But over the next hour, I wanted to present a broad overview of some of the latest findings in autism research, as well as some of the latest activities that Autism Speaks is sponsoring, funding, to really accelerate the research and the understanding of autism spectrum disorders. And I want to start with this number, because this number is incredibly significant. And in the last few weeks, there's been a lot of buzz in the media around the new numbers that the Centers for Disease Control just released based on the recent set of findings. 1 in 88 children born in the United States will develop an autism spectrum disorder. When I started in the field back in 2003, the rates were 1 in 500. Then they moved to they increased to 1 in 250, 1 in 166, 1 in 150. At the beginning of the year, it was 1 in 110, and now it's 1 in 88. It really is what we feel a public health emergency. And from the research perspective, there are lots of reasons why that we can explain this increase, and the field is really split in some ways in terms of, is it real, is it not real, and there's validity to both sides of that discussion. But we do know that autism affects boys 4 to 5 times more than it does girls. And researchers really are using that as a clue to try to understand both the etiology or the causes, as well as trying to understand how we can potentially think about treatments for these individuals. So yes, this is a very, very serious issue that we have on our hands. The 1 in 88 kids is a 78% increase over the last 6 years, and a 10-fold increase in reported prevalence over the last 40 years. Over the last 6 years, as the prevalence numbers have almost doubled, the cost to society has more than tripled. So whether you believe the 1 in 88 or the 1 in 110 or not, the reality is that as a nation, we are all being affected, and we have a responsibility to try to manage that. Today, autism costs our nation a staggering $137 billion, and that number continues to grow with the rise in prevalence. One of my good friends and colleagues, actually here in Pennsylvania, Dr. David Mandel at University of Pennsylvania, was funded by Autism Speaks to conduct a study on the costs of autism, and another colleague was funded by Autism Speaks to do a comparative study in the UK. And while the annual dollars may the total dollars may differ, the ratios are the same both here and across the pond. But in the US, the total cost for caring for one individual over his or her lifetime is $1.4 million for a person with ASD who does not have an intellectual disability. When you add intellectual disability to the mix, the costs are about $2.3 million. So think about the impact that that has, not only on one family's life and bank account, but also the cost to society. A lot of people say some of the results of these epidemiologic studies suggest that autism does not affect minorities, Hispanics, African Americans, in the same ways that it may in the Caucasian population. But what we also know is that there are significant health disparities among minority families. And so those statistics, and the researchers will recognize that, may not really affect what is real. Autism Speaks funded a study in South Korea, and it was population-based, door-to-door sampling. And the researchers who were trained at Yale, who were conducting the study, found rates of 1 in 38 children who were affected with an ASD. And that's in South Korea. So autism is not something that will spare any particular race, ethnic group. There are about 1.5 million Americans living with an ASD. And the reality is that while a lot of the research is focused on early identification, early intervention, and on the little ones, the reality is that we have a growing adolescent and adult population, and we must focus resources there. A lot of these staggering statistics that I've shown you with respect to costs also reflect caring for adults with autism, whether it's residential care, out-of-pocket costs for medically related issues, and a lot of the different associated costs that are relevant to adults living with autism. And Autism Speaks has invested close to $174 million in scientific research, but we need a national strategy because we can't do it alone. So it really is a call to action. So this is what we consider to be the public health challenge. Let's put it all in context, because the 3 disorders listed here receive significantly more research dollars than autism. Cystic fibrosis, 1 in 3,500. Childhood cancer, 1 in 2,000, and these are the rates. Type 1 diabetes, 1 in 400. Autism, 1 in 88. So we need parity. One of my colleagues many, many years ago, he made the comment and he said, you know, if 1 in every 88 kids were being kidnapped from our schools, wouldn't that constitute a national emergency? You bet. So we really need to take this statistic very seriously. And again, whether it's 1 in 88 or 1 in 110 or 1 in 150, these are very real costs, and these are very real kids. And more children will be diagnosed with autism again this year than with AIDS, diabetes, and cancer combined. So what can we attribute this increase to? Because there are a lot of different factors that really do explain the increase. So one alternative is that it really is a genuine increase, that it just keeps going up and up and up. Now, another interpretation is that as we broaden the criteria, as we get savvier about diagnosing the disorder, as we start changing the way that we will diagnose. Many of you are familiar with what we call DSM-4 criteria. Autism is still under the rubric of psychiatry because it's considered a psychiatric disorder. And we do not know, there is no biological way for us to determine whether a child or an individual has autism or not. So we're really limited in terms of how we can diagnose a child is really limited to behavior. So the Diagnostic and Statistical Manual for Diagnosis is the psychiatrist's Bible. But over the years, the DSM gets updated and modified and uses real research and the evidence to modify the criteria. Well, we are approaching the DSM-5, which is just the new iteration of this Diagnostic and Statistical Manual. And so as you change the criteria, people will be falling into different categories. So some investigators have suggested that with the changing criteria, you can get more kids falling into the ASD bucket. There are also increased services. And so I know that in some states, some services are covered, behavioral services, whereas in others there aren't. And so there are some practitioners who may tend to overdiagnose because just to ensure that families get services that they need. And so that could also be contributing to the increase. And there's also improved awareness. So as more and more people become aware of the signs and become aware of autism spectrum disorders generally, there may be more of an increase because parents are responding, they're getting their kids evaluated. So there are lots of different reasons that investigators have proposed to explain that increase. But here's the reality. Our schools, our special ed classrooms are flooded. Our treatment centers have year wait lists for evaluation. And in terms of the Autism Treatment Network, which I'll talk about in a second, we can't see kids fast enough. There aren't enough doctors and professionals that are available to take care of our kids. And that is very real. So I want to talk about, now that I have your attention, I want to talk about autism spectrum disorders as a group of complex disorders. So the way that I like to define autism and the spectrum in general is that autism really is a neurodevelopmental disorder. All of the science really suggests that it affects the way the brain develops, the development of the brain and the nervous system. The current diagnostic categories focus on three core areas. So these are areas of impairment or deficit. First, social deficits. The second is language impairment. And the third is repetitive behaviors. And in order to have a diagnosis of autism, you have to meet criteria in all three of those areas, meaning you have to have deficits in each of those areas. As we move towards the DSM-5 criteria, we're focusing on 2 rather than 3 core areas. And we're losing the language. The language impairment is the way that they're organized are different. It categorizes the disorder more on a continuum that seems to be much more true to life. Regressive autism affects between 15 and 40% of individuals with autism. And often those are some of our more complex kids. And what that means is that children start developing typically, and they're hitting their developmental milestones, and that around 2 years of age, there will be a regression, meaning there will be significant loss of skills learned. And that's what we call a regressive autism. So it can manifest as loss of words after the functional acquisition of at least 5 words or phrase speech, and they lose it all. Or the regression is also categorized as part of the diagnosis. So is it autism with regression or not? Because what we're starting to see, the findings that are starting to emerge is that children with regression, children with autism that also have regression, may represent a separate subgroup of kids with autism. As I mentioned, they're the more complex kids, and we'll talk about some of the research in a minute. Autism is what I call it's not just about the brain. It's about the whole child, because it does affect multiple organ systems. It does affect the whole child. It has a lot of co-occurring medical conditions. We'll talk about those a little bit. Sleep, it affects the GI system. Epilepsy is frequent in a subgroup of these kids. It also has comorbid psychiatric conditions, which will be discussed later on in the throughout the course of the day. And then there are some somatic symptoms. So all of these are the core deficits, and a lot of the associated symptoms really represent what we call autism spectrum disorders. But the 3 core areas of impairment up until now have been the 3 here in orange. So thinking about ASDs as a systems disorder, from a research perspective, which features of autism can help us really understand the causes and the complexity? So by really understanding, a lot of researchers are trying to understand and focus on some of these other systems to determine what's the underlying pathophysiology. From a mechanistic perspective, going back to your high school biology and chemistry, what could be going on? It's a neurodevelopmental disorder. You just don't catch autism at age 8. So it affects the way that the brain develops. The way the wiring of the brain is set up from a very young age. And so how can the wiring of the brain, how can the development of the nervous system, how does it manifest across all of these different systems? A lot of people say to me, you know what, Clara? You have some of the brightest minds working in autism. You're spending a ton of money. Why can't we understand what's going on? And what you'll see here is that research reflects the complexity. These are a lot of the different areas that have been studied, and they're incredibly diverse, from genetics to biology, to sleep, to GI. They really reflect the fact that this is really hard. When we think about the biology, the first thing people ask, well, is it genetic? Is it the environment? I keep getting mixed messages. Now, to take a step back, when we think about the fact that all of us are 99.9% identical at the genetic level, you think, oh my God, are we really just looking at that 0.1% that makes us all different to help explain whether one person is more susceptible to disease than another? By studying these patterns of genetic variations or differences, researchers expect to identify the differences that are related to a particular disease. And while twin studies show that autism is highly genetic, highly inherited from parents, it's not 100%. So then, of course, we have to ask the question of, okay, if it's not 100% genetic, then what's going on? Some of the latest flurry of genetic findings have really focused on what are called copy number variations, de novo, new spontaneous mutations. And these are mutations. What they are is that they're either duplications, extra copies, or deletions, missing some copies of certain parts of genes in the genome. And in the past, this was referred to as junk DNA. And most people didn't feel that it really played a role in anything. It just kind of sat there. Well, now, not only in autism, but in other disorders such as schizophrenia and Alzheimer's, people are starting to realize, wow, we're starting to see a preponderance of these CNVs in individuals with autism, an increased rate of CNVs of individuals in autism versus individuals who do not have autism. And what's more interesting is that these mutations that have been associated with autism are not present in the parents. So if it were highly genetic, you would expect to see a lot of these mutations in the parents. The fact that we're not seeing them really speaks to something else. And so researchers, I think that they all agree that we know that it's not solely genetic. We know genetics are involved, so it's not solely environmental. So it's likely a combination of both. And the interplay is what we have to figure out. But without that, all of the last decade of genetic research, we wouldn't be where we are. So what we're talking about are these complex interactions among genetic and environmental factors which contribute to risk. And the important thing here, and I'm going to repeat that throughout my talk, is that it's not causative. There is no one gene. There's no one cause. It's increasing risk. It's almost as though you have a bucket and you keep filling it up and filling it up and filling it up with whether it's environmental toxins or a lot of these susceptibility issues. And then once you hit a tipping point, perhaps, if the entire system is pretty fragile and compromised, then that can really set off a chain reaction. So some folks say, well, let's look at protective factors. We know that autism affects boys 4 to 5 times more than it does girls. So is being female protective. And there is some early research to suggest that estrogen could in fact serve as a protective factor. Folic acid. Could taking folic acid early on be a protective factor? There are environmental risk factors. And again, we can't point to just one. And there's not enough research to actually prove that even any of these is a surefire hit. But some of the ones that have been suggested, sorry, it's my calendar. I'm supposed to be here right now. Parental age. And one of the recent genetic papers that just came out, I believe, in the last 2 weeks, really suggests that a lot of those spontaneous mutations that I spoke of, the CNVs, are traced back to older dads. That older dads seem to have be contributing an increased risk. Prematurity, a risk factor, but prematurity can be a risk factor for a lot of other disorders, not just autism. Maternal infection increases the risk. Maternal antibodies, organophosphate pesticides. A lot of these are called environmental risk factors. It's not just a toxin, perhaps, but different types of factors that may increase risk. And then there are common genetic variations that also increase the risk. So what I'm trying to get across is that this is a very complex system. We're not talking about a single gene disorder where there is one gene that goes awry or that is compromised to cause disease. This is much, much more complex. Then you have rare genetic mutations that are strongly associated with ASD. And in perhaps up to 25% of the cases, we can say, yes, if you have this particular genetic mutation, that is pretty likely the cause of your child's autism. But that's not a high percentage. Most of them are what we call idiopathic. And one of my best friends, and I can say this because she's a child neurologist at Boston Children's, she said to me, I said, idiopathic, huh? And she said, yeah, because the doctors are idiots and they can't figure it out. Right? And so really what we're left with is a large number, the majority of cases of autism where we don't know what the cause is. And that's what makes this so hard. We also know that the presence or absence of associated symptoms and or comorbid medical psychiatric conditions may have a differential effect on severity of illness and outcome. There are some studies that show, or that suggest, the data suggest, that individuals with GI issues also have severe GI issues, or also those kids that have regression. And the kids with regression often tend to be more complex, whether it's medically complex or complex in other ways. And so a lot of them are nonverbal. So again, we're talking about different groups of kids, and from a research perspective, it would be wonderful, it's a strategy that we all think about. Wouldn't it be great? We think about the way we think about cancer. So breast cancer, for example. There are 10, apparently physicians can really look at breast cancer and categorize breast cancer into 10 different buckets, from mild to severe, and by severe I mean aggressive. And so we know that, in fact, the field of pharmacogenomics, meaning being able to use the genome to help predict a positive response to a particular drug, has emerged from the cancer world. But that's one of the goals of the autism community, the scientific community, is to really think about how can we better categorize these kids so that we can start to understand what could be the underlying biology, and B, whether we can start targeting treatments more specifically to individuals in targeted groups. So again, is it autism, one disorder, or is it autisms? I bet that everybody in this room would probably say, especially those of you who know a lot of individuals with autism, who have children or living with children, or have adults with autism living with them, would say, yeah, it's probably not just one thing. So what I want to do is highlight Autism Speaks every year, as well as the National Institutes of Health, they come up with what they feel are the top 10 scientific advancements of the year. And Autism Speaks on its website, and you can feel free to go and take a look at our website. We too, in the science department and among our group of scientific advisors, we came up with our top 10 achievements. And I'm not able to talk about all of those achievements, but I've identified some that we can, just to kind of let you know what some of the latest research is currently in the field. I've already mentioned the twins, and I just wanted to summarize the twin study that we published last year on to say it's more than just genes. And a lot of people have viewed this as a game changer, and others have said, you know what, again, getting back to measurement, you're just measuring it better. You're just able to see, perhaps these findings were there all along, but you just didn't have enough twin pairs in your study sample. So getting back to identical twins and the notion of, is this genetic or not? Whenever you want to understand whether the heritability of a particular disorder, regardless of what it is, you want to turn to identical twins because they share 100% of their genes. They're genetically identical. Fraternal twins, however, only share 50% of their DNA. And the only difference between fraternal twins and regular siblings is that the fraternal twins are born at the same time. Okay? What we did is, so we compared autism rates in both kinds of twin pairs, both the identical ones and the fraternal ones. And we found that the rates of autism among identical twins for the spectrum was 70%, meaning when one twin had autism, and this is between 70 and 90 if we want to look at all the literature, between 70 and 90% of the time, the co-twin was on the spectrum somewhere, okay? And again, what would we expect if it was a purely genetic disorder? 100%. Now, when we looked at fraternal twins, okay, the rates were 34%. Now, this really kind of freaked a lot of people out because we've all known that autism, you know, it's a genetic disorder, and we knew that there's that for a long time that it was likely the result of some gene-environment interaction. But the prevalence rates among the fraternal twins have always been low, 7, 10%. So the fact that we were able to see 34% was huge. And so what the study through modeling, my colleagues up at Stanford did the modeling, I can't speak to any of it at this point, they reported that the genetic contribution was 32%, and that was less than the environmental, which was 62%. So even though we've always known that there's some kind of gene-environment interaction, we were surprised by the degree to which this was due to some kind of, or resulted from some kind of environmental effect. So what we can say here is there's something about that shared environment among that's what's exciting about this study, that really kind of puts the focus more on some of the pre and perinatal exposures that could increase risk. And this was supported by a grant from the NIH, from the government, as well as Autism Speaks. The second study I wanted to talk about it has to do with our baby siblings. Are baby siblings at risk? And our colleagues up at the Mind Institute at the University of California, Davis, reported that younger siblings have close to a 20%, 1 in 5 chance, 20% of developing an ASD. And this is considerably higher than the previous 3 to 10% estimates. And now the previous studies used much smaller groups. So this, if in research, if you really want to know whether an effect is real or not, that you want to look at many, many more people, because if you focus on small groups, there's a high probability that that could happen by chance. So the larger the group, researchers feel, the more confident the finding. The researchers also found a higher rate of autism among baby brothers. And again, given this 4-to-1 ratio, that was aligned with what we saw, but still, it was pretty high. So 25% higher rate of autism among baby brothers than baby sisters. For infants with more than one sibling on the spectrum, that rate increases even more. And I know in my very prolific introduction, Rich mentioned that one of the programs that I've developed and I oversee is the Autism Genetic Resource Exchange. And what we do is that we recruit families and we collect genetic and clinical information on families that have more than one child with autism, because we've been focused on trying to understand this. And I have families with 2, 3, 4, 5, and 6 affected kids. So again, the rates have increased. They increase with the incidence in families. Now, researchers at the Mind Institute are part of what Autism Speaks has a baby sibling research consortium, and now is when we're starting to see so much research great research that's being generated from that group. The next study I wanted to talk about has to do with the immune system, and this has been a finding that a lot of parents will say, you know, we said that 10 years ago. Glad the science has finally caught up with us, because really, you know, parents really are our greatest teachers. And researchers again at the Mind Institute reported that many kids with ASD have signs of ongoing inflammation. And what they did is that in blood samples, they looked for inflammatory markers in the blood called cytokines. And they found that they were much higher in kids with autism than in those who didn't have the disorder. And if you look at the sample and the way that they approached it, they had 223 kids between the ages of 2 and 5 with autism. They also had a group of kids that did not have autism, but had other developmental disorders. And then they had a group of kids that were just typically developing, that had nothing. Because if you're making that kind of claim, you want to make sure that you've controlled for it appropriately. And further analysis showed that these increased levels of cytokines occurred primarily in children who had a regressive form of autism. And so when you think of some of the GI issues that these kids have, a lot of folks and parents have long said that it's a sign of ongoing inflammation. So again, it's another clue that we're able to validate clinically. And these findings suggest that ongoing inflammation may be linked to some forms of autism and autism-linked disabilities. So again, that can help us think about treatments. If this proves to be a real finding, then we can start thinking about how to determine at what time point, and then thinking about treatments that we can use to target, to protect, even perhaps mitigate it. Another study has to do with the changes that I already talked about, these de novo or new or spontaneous mutations that provide new clues. And again, in one particular study, this is not just one study, but this is the result of about 4 papers that came out all around the same time. And researchers have identified hundreds of these mutations in the DNA of kids with autism and found that they were increasingly frequent in kids born to older dads. And when I say older dads, I'm not talking about dads in their 50s and 60s. We're talking about dads in their late 30s and 40s. So it's something that we have to think about. Now, some of you will say, well, my child has autism, and we were in our 20s when we had kids. Again, this is not causative. This is an increased susceptibility. And when we think about society, women are waiting much later. They're focusing on careers to have kids and families. And so men and women together are much older in general in terms of wanting to start their own families. So again, one of the things that was neat, and I'm not going to read everything in here, is that the genes that have been identified, they are really all involved in brain development, which is good, because if you're starting to identify genes that are involved with, you know, the knee or the elbow, you'd think, okay, that's like off. But they're all involved in brain development in one way, shape, or form. And again, one of the studies confirmed and found higher rates of these spontaneous mutations in kids with ASD, more so than in their unaffected siblings. So it really does have something to do with the autism. And the last study I wanted to talk about has to do with early autism screening. Because this was a study that was conducted again in California. I swear I did not just focus on California. It just fell out that way. UC San Diego, where researchers found that they developed a brief parent questionnaire, because the notion is, well, we want to be able to screen as much as possible. And there's a lot of controversy around that, because the American Academy of Pediatrics, their latest recommendations is that that children need to be screened twice at 18 and at their baby well checks. And so, but the problem is that we need to be careful that we're not screaming fire in a movie theater. And others feel, well, it doesn't matter. If a child is falling off their developmental trajectory, we need to know that, and we need to correct that as quickly as possible. So this researcher involved 137 pediatricians to target about 10,000 families who handed out this screener. It took 5 minutes to complete. And the screen was able to accurately predict autism or developmental delay about 75% of the time. Now, that's not, again, 75% is good, but it's a lot of kids. And so the positive predictive value of the screener is okay, but we need to improve and refine it. But it does suggest that a questionnaire, a 5-minute questionnaire, could really identify kids that are truly at risk, really, really young. And that's the point. Because getting back to early intervention, we know that the brain is very malleable, and we call it plasticity. And you can really alter the trajectory of brain development early on. And some of the thinking, and this results not only from behavioral studies but also brain imaging studies, is that you can really change the course of brain development through early intervention. So it would be very important to identify kids early on so that you can improve their IQ, perhaps, improve language, improve joint attention, a lot of the factors that we know contribute to a very different outcome. Autism Speaks Autism Genome Project, which is an international collaboration, in 2010 identified new genes and pathways involved in autism, again, all pointing to brain development. And again, a lot of the pharmacology that we're looking at, and again, this complicated diagram, which I thought was just really beautiful, it really speaks to the fact that autism's cause may reside in abnormalities at the synapse. And the synapse is just this the space between neurons or brain cells, and it's the mechanism by which they communicate. So if that bridge or that mechanism for communication is off, it's split, if one of your bridges went down, you'd know you couldn't get to the other side, right? So that's what we're talking about here. That the evidence is pointing to the fact that perhaps that's the area. And then a lot of pharmacology can really be targeted to improving that. Neuroligin genes, the SHANK3, neurexins. So these are a lot of the genes that have been implicated in autism. So now I want to shift gears entirely. And now think about, so we've talked about the biology. We've talked about some of the findings regarding screening, perhaps early intervention, genetics, recurrence risks. And now I want to talk a little bit more about the impact of autism on healthcare. Because we talked about autism as being a systems disorder. So we know that it's neurodevelopmental, a lot of psychiatric comorbidities, epilepsy, for example. But what else does it affect? And I want to propose that this is a systems disorder. We know that there are higher rates of hospitalizations and longer stays among kids with developmental disabilities. We know that there's higher healthcare utilization for outpatient as well as medications. These kids require specialty care, which is why it was what sparked our notion of an autism treatment network. And there are greater unmet healthcare needs than other kids with, even other kids with other special healthcare needs. And what we've been seeing is that kids with autism have a lower quality of life than typically developing kids and even other kids with chronic conditions. So treat the whole child, not just the behaviors. And when you think about the child, it really is in the context of a family, a healthcare setting, a community, and all kinds of educational and community services. And so autism really has a significant impact on quality of life. Many times these issues go unrecognized, these medical issues go unrecognized and untreated, and they can contribute to the behavioral challenges. So the notion is that if a child isn't feeling well, take a nonverbal child who has had chronic diarrhea for 2 years and is not able to express the pain. They're going to manifest they're going to express it behaviorally, whether it's in school, whether it's tantrums, whether it's meltdowns, whether it's perceived psychotic episodes. They may be manifesting. They may be trying to tell you something that they're not feeling well. And it's hard to think about that. And there are barriers to integrated care. for healthcare professionals, it's been a lack of awareness about the association. So oftentimes, a parent will bring their nonverbal child in and say that, that it's caustic diarrhea for 2-3 years, and they'll say, well, it's the autism. Well, no, you need to treat the diarrhea, regardless of the autism. And that's been something that's been, that professionals now, with all the work that we've been doing on the awareness side, is starting to shift. There's lack of training in the assessment and treatment of these kinds of health issues. There are few agreed upon standards of care. So if you have a child with cystic fibrosis, you can take them to one of many children's hospitals, and they can go into the cystic fibrosis clinic, and there's a protocol for evaluation, and there are treatments that are offered, and you'll just go and run through that. If you have a child with autism, nothing exists. You have to piece it all together. And that's one of the reasons I'm getting ahead of myself for the Autism Treatment Network. But there's tremendous variability. With respect to the development of standards and what the barriers are there, the underlying biology, we don't understand it. Okay? Despite the research, we still don't really understand it. And there's variability in consensus. Some people will think this way, some people will think that way. And again, there's a greater breadth of clinical research that is needed for evidence-based standards. So we can't, it's show me the evidence. And then we need to determine the need for autism-specific standards. So is it sufficient that the American College of Human Genetics recommends genetic testing? Do we need to change that and make it different for kids with autism? Well, the consensus is probably not. But in the world of GI and the world of sleep, if these kids are different, do they have to abide by different practice parameters? So the ATN, it's a model for comprehensive care. It's an integrated model of care in the same way that I just mentioned the Cystic Fibrosis Network has worked. And the mission is to establish a care that's sustainable for delivery and evidence development. So what we have to think about, it's primarily focused on the medical issues, and how can you think about treating all of the issues in a systematic way, using a standard evaluation. And we're very proud to say that here in Pittsburgh, we have one of our 17 ATN sites. So we're really thrilled that to make that available to you in your community. So again, 17 medical centers across the U.S. and Canada, supported by Autism Speaks, and we have a $12 million grant from the government to conduct research on medically related issues. We have over 350 clinicians in 6 subspecialties, and well, now it's greater than 28,000 children and families are going to be served. Now, I mentioned that 1.5 million Americans are living with autism. So 28,000 doesn't even, you're not even touching it. But what the Autism Treatment Network is doing is establishing standards. They're trying to do the cutting-edge research, trying to put the findings together, developing the model of care so that we can then push that out and focus on dissemination and training for doctors and practitioners around autism. So what's unique? Well, we're developing clinical guidelines. We're establishing toolkits for the field for both professionals and parents. We have ongoing research, and we have a patient registry that's very, very impressive. It's family-centered care. We're providing a model that broadens the reach to local communities, and it's a very well-established clinical and research infrastructure. We have over 4,700 kids enrolled in the ATN, 13 federally funded projects, and more than 1,500 kids are enrolled in ATN research. So it's really exciting what this has done. And these are just the demographics telling you we have a 5-to-1 ratio of boys to girls, and our ethnicity is primarily white, and that's the split in terms of diagnosis. So let me just touch upon what's our process to develop these clinical practice guidelines. So they're targeted to primary care providers, pediatricians, developmental pediatricians, family practitioners. The long-term goal is to move from consensus-based guidelines, meaning what the doctors in the ATN are thinking is what should be, and gathering evidence to actually either support or refute that or change it. And the clinical practice pathways are developed based on current literature as well as the consensus. Now, one of the big things that Autism Speaks has really promoted is the development of toolkits. And the Autism Treatment Network, each of in order to qualify as an ATN site, And those of you who run departments and department chairs know that this is not easy, because running an autism center is not a cost-neutral proposition for any hospital. It's losing money. Most of them are running at a deficit, where it's not cardiology, it's not radiology, it's really tough. So what the ATN does is really starts thinking about, it brings together, you, in order to qualify, you have to have dedicated group of physicians and clinicians that include a neurologist, a sleep doc, a GI doc, a geneticist, so an expert in genetics, metabolics, psychiatry, and psychology. And they have to have dedicated time to the ATN. They have to participate and be available to be part of the evaluation process. And each of those individuals will work in their subcommittee, a subspecialty subcommittee. One of the things they're doing is developing toolkits for families and providers. One of our most impactful toolkits has been, should my child take medication for challenging behaviors? We also have two that one of them says taking the work out of blood work, helping your child with ASD, and also one for the hospital or the medical center trying to draw blood from individuals with autism. These are the different toolkits that are in progress, and many of them are already available on the Autism Speaks website. We've partnered with our Family Services Department, who has also put out what's the 100-day kit, which is fabulous. It's the first 100 days, basically navigating the first 100 days post-diagnosis. And they also develop different types of toolkits, for example, on how to get a haircut, issues with schooling, how to deal with individuals with Asperger's in the community. So again, a lot of wonderful toolkits are coming out of both the ATN as well as our family services. So I just want to focus now the last few minutes of my talk on common comorbid conditions. And by comorbid we mean whether it's psychiatric or GI or whatever the case might be. And kind of thinking more about the identification, treatment, and management of these conditions. So when we get back to what are the areas of impairment, remember I opened up with that slide that showed the 3 core areas of deficits: social communication, language, and repetitive behaviors. And then there are a whole host of those other things, associated symptoms. And what I'm going to do here is focus on these: sleep, GI, epilepsy, and I don't know that I touch upon too much comorbid psychiatric diagnosis, because I know it's going to be touched upon by the actual experts later today. But what you can see is some of the rates among individuals with autism. So sleep. Sleep problems affect between 50 and 80% of kids with ASD. And what the common problems really are: insomnia, night terrors or sleepwalking. Some have obstructive sleep apnea, restless leg, periodic limb movements. And I mean, the impact, you know, what happens when you don't sleep? I mean, I've been traveling so much, and, you know, last night I found that at 4 in the morning, it's really, people aren't using the wireless network, so you can really, it really goes much faster, right? You know, when you don't sleep, you don't feel well. You have poor concentration, poor attention, poor social interactions, you name it. So for an individual with autism who's compromised out of the gate, this really can be very debilitating. So these disorders affect kids across the age range and also across cognitive levels. And the reported sleep problems in kids with ASD, I want to be very clear, are different from those from kids with that are typically developing that might have a sleep disorder, or other kids with other developmental disabilities. Sleep problems are also associated with things like GERD or reflux, constipation. Kids with sleep problems have sensory issues, dental issues, seizures, and these are all things that have been associated with the sleep issues in kids with autism. And then the psychiatric disorders, meaning either depression. Kids with depression have early morning wakenings. Bipolar kids have a decreased need for sleep, probably the mania. Anxiety, they have problems falling asleep alone, and some of the psychotropic medications can certainly cause sleep issues, and certainly there's been an association with some nutritional issues as well. So for those of you who are parents or educators or providers, what are some of the behavioral red flags? So, You know, excessive daytime sleepiness. Now it's hard. You have to tease that apart. If you have a child who's on a medication that can be a little more sedating, that can also be a problem. Frequently falling asleep in cars, and now little kids are supposed to fall asleep in cars, but much more than is typical. Napping during the day, which is outside the child's typical routine, moodiness or short temper, changes in mood or temper, and changes in the ability to concentrate. Again, it's a change. The evaluation starts by ruling out medical issues. That's step one. We want to make sure that this isn't the result of a sleep apnea or that there aren't other conditions affecting sleep, such as a psychiatric disorder or epilepsy or a GI disorder. You want to do a comprehensive behavioral evaluation. Typically, they'll do a sleep diary to look at sleep habits and look at other behavioral measures. The current standards are what you see here. The AAP stands for the American Academy of Pediatrics. They have identification and management of autism. They have an autism-specific toolkit. But there's limited information on sleep in that particular toolkit. And the autism, it's a resource, but not a guideline. And condition-specific guidelines are not ASD-focused. And you're going to see that as I touch upon the other comorbid conditions. So what is the ATN doing to try to help change this? Well, we have a toolkit for physicians, and there's also a parent pamphlet. And again, it's on our website. Sleep education materials, we have a randomized controlled trial. It's a comparative effectiveness trial of sleep education. My colleague at Vanderbilt, Dr. Beth Mallow, who's a sleep expert and actually now got an endowed chair there so that she's focusing on autism. She's working on this a lot. There's a committee that's developed it. We've just developed a practice guideline in partnership with the American Academy of Pediatrics on sleep. And the ATN practice pathway on sleep is to be published in 2012, this year. So we're really excited about that because partnering with groups like the American Academy of Pediatrics is very important in terms of getting buy-in from the broader community. So the behavioral approaches are, there are daytime habits that you can control, evening habits, sleep environment, controlling that, and also things like, I had a parent who said, I really don't know why my kid doesn't sleep. And so I started to probe a little bit, and in my mind I was doing a little bit of a sleep hygiene evaluation, and I discovered that around 3 or 4 o'clock every day she's giving this kid like Mountain Dew. I won't sleep for 3 days, okay? So there are some common sense things, and then, you know, I mean, the look of horror on my face, she probably thought like, what? I mean, you really want to be smart about this, you know, make sure that you're not giving your kids excess, you know, Red Bull around 6 o'clock. Really thinking about what makes, if a child wants a soda because they're going to McDonald's to have their chicken McNuggets, no, try for a different alternative. So things like that, which are more obvious, a lot of parents just, they don't really put 2 and 2 together. Now, management of sleep issues, there are also medication and supplements that you can take. Melatonin is one of the treatments that's now being studied much more so than anything else. Melatonin is just a natural hormone that regulates sleep, and it's available as a supplement. I personally take Dream Water when I travel because it's melatonin and a whole host of other holistic stuff that in my mind I think that I'm actually going to sleep better. But what it does is that it really adjusts the sleep-wake cycle. And we have some trials in terms of supporting the use for kids that have sleep onset delay. So we're targeting the onset of sleep, not the maintenance of sleep. And so that's very important to understand what the point, what kinds of what some medications, whether they're more kind of things like melatonin or other pharmaceuticals, what they're really going to be targeting. So there's not as much evidence for use of melatonin in sleep maintenance. Common medications on the psychopharm side that are used are things like clonidine and trazodone. And then some medications like the anticonvulsants, they have some sedating qualities, and so they will be given as a sleep aid. So again, this is more kind of off-label use. The doctor will say, well, I think this might help. And oftentimes they do. Even though they're not targeted, they're not sleep drugs, sleep meds per se, they may be prescribed to help kids. Now let's switch to seizure disorders and epilepsy. So we went from sleep, and epilepsy is something that's associated with sleep. The literature suggests that seizure disorders can affect up to 30% of individuals with ASD. The most consistent finding I've seen is it's closer to 17%, but there, again, this is the literature, so it's the range. And the common problems are actual epilepsy or these abnormalities that you might see on an EEG when they do an evaluation. And the impact is, kids with epilepsy also may represent a very unique subgroup. They're sick kids. And this is for the kids that have early onset epilepsy, so when the kids are really little. Now, there's a lot of clinical anecdotal evidence right now, and I'm hearing it from families as well as from doctors, that as kids are entering adolescence, something's going on, and they're starting to see seizures where they never had seizures before, and now that they're entering adolescence, they're starting to have these convulsive episodes. For some kids, it's sporadic, and for others, it's become a chronic condition. And so one of the areas of investigation is endocrinology. So as kids enter puberty, could there be something hormonal going on that's really triggering this? There are lots of factors, lots of hypotheses that have been proposed in that way. But again, the impact is poorer outcomes than these kids have poorer outcomes than kids with autism that don't have epilepsy. And there's a higher prevalence in kids with motor impairments, intellectual disability, and interestingly enough, females epilepsy in females is often associated with cognitive impairments. And so it is very important, and they do present as a unique subgroup. So what are the behavioral red flags? Okay, here we go. Unexplained staring spells. I'm just talking too much, probably too long. Yes, I'm a little over time. Involuntary movements in the face or limbs, if you notice that. Sleepiness or sleep disturbance. Again, it's very important to get a comprehensive evaluation because you need to be able to tease this apart. Is this epilepsy? Is this sleep? Is this something else? You can't just say, oh, it's this. And that's why you need you could benefit from this multidisciplinary team approach, because you really have to have, the doctors really have to be driving this. Regression is another behavioral red flag, as well as unexplained confusion. And some of you might be thinking, wow, when I think of if you have family members that have Alzheimer's, it's like some of these things are also going on in some of my family members with Alzheimer's. So again, whereas autism is neurodevelopmental, Alzheimer's is neurodegenerative. So we're starting to be able to look at the Alzheimer's literature and starting to kind of use that to make inferences, or starting to as launch points for more research. There is no standard recommendation to do an EEG, which is the way that you would measure brain waves, the electrical activity in the brain, on every child. And again, the ATN has thought about, okay, should we do an EEG on every child? Kind of prophylactically, just kind of do it and then see, because you will have there is actually a paper that's getting ready to be published that's presenting some interesting findings, that perhaps that there are kids that don't have a seizure disorder per se, but on the EEG, they have some of these spikes. But an EEG is recommended for kids with specific, the red flags that I just mentioned. And again, current standards for treatment and management, the American Academy has, and then the neurologists also have standard practice guidelines that they use. But there's limited information on evaluation of epilepsy in that AAP toolkit. But the Autism Treatment Network is developing, again, clinical practice pathways for EEG that's based on evidence. And that's going to be published in 2012 as well. So what are the treatments? The anticonvulsants or the anti-epileptic drugs. Severe cases. And for some people, some physicians might consider this experimental or there's not enough evidence, but some of the more severe cases may warrant either surgery, that brain surgery, or what's called a ketogenic diet. And it broke my heart to see, because this is a really hard diet, and to see some kids with autism, what they endure is just unbelievable to me in terms of diets and things like that. But this particular diet, some families have seen improvement. In terms of either no seizures or reduced frequency of seizures. It's a high-fat, okay protein, but low-carb diet. And again, more research. I know families that have done it, and it's not done anything for their kids. So when we think about GI disorders, I know I'm going through this pretty quickly. We're talking about things like, and these are increased rates of GI disorders in kids with autism: GERD, reflux, Prilosec, Tagamet, all of those drugs that we as adults take because we sometimes, we hit that fast food joint just a little too much. Things like chronic diarrhea, chronic constipation, abdominal pain. These are all kinds of GI, these are the symptoms of GI disorders that these kids may manifest. And they have a greater impact on kids with ASD than, or greater challenges than the kids with ASD without the GI problems. And they affect, obviously, behavior, sleep, lower quality of life. Physicians may attribute GI symptoms to ASD. So it's the autism. And parents will say, whatever, okay, but you need to help my child. My child's in severe pain. So, but some of these, especially in kids who are not able to express pain, uncommon symptoms also make them harder to identify. So again, the standards and limitations are the same as what I've presented already. But the GI subcommittee is publishing constipation algorithm in the journal Pediatrics this year. It's going to be coming out. We're hoping it'll be sooner rather than later. We have ATN sites setting up clinical studies to evaluate and validate the use of this algorithm, but we are really excited about that. So in terms of red flags, some of the more uncommon symptoms: aggression, and you can say, well, aggression, that's pretty broad. So again, you can't just say, oh, my kid's aggressive, therefore he must have a GI disorder. That's an easy place to go. But you got to be careful because aggression can be a byproduct of a lot of different things. Agitation, self-abusive behaviors such as biting or hitting oneself. So these self-injurious behaviors could be a sign that there's something else going on. Posturing. So one of our colleagues who was instrumental in writing a lot of these practice guidelines, he is up at the Mass General Hospital in Boston, and he's a GI doc, and he says that kids sometimes they'll bend over furniture, and kind of because something hurts, but they can't tell you. Arching of the back. Some kids will go like this with their chin, to their chin, and doctors for the longest time couldn't figure out what that meant. And they started to see that in kids that had GI issues and that were nonverbal, they would go like this. So it's interesting that clinically what you really have to be careful for the physicians or the clinicians in the room. You have to be careful in terms of thinking about really looking out for some of these red flags. Teachers, I mean, our kids spend most of the time in school. Really educating our teachers about some of the red flags for each of these is important so that they can say, yeah, he's leaning over the chair all the time. And is he just trying to disturb the group? No. It could be that he's in pain. So reclining, lying down in the case of GERD, there's a video that Dr. Bowie presents that's really incredibly compelling about this young girl. She must have been 9 or 10 years old, and she'd broken 4 beds, wooden beds. And in the video, I mean, for me, in terms of I've been mostly involved in psychiatry, and she looked like she was having a psychotic episode. And the clinician said, oh, she's having psychotic episodes, something's going on. And what you would notice is that she would, at a certain time of day, now that should have been the trigger. It was in the evening, and at a certain time of day, she would flip backwards onto her bed, nonverbal, but flip backwards aggressively over and over and over again. And then Dr. Margaret Bauman, who's also at the Mass General Hospital, she said, I want to send this kid for a GI evaluation. And I mean, the link, I would not have made that leap. And when they scoped this child, they realized she had esophageal ulcers from top to bottom. And what was happening is that she had reflux. And when the acid would come up, can you imagine having ulcers and then having that acid and then that acid pain? And so what she would do was arch to try to relieve that pain. And in doing so, she'd flip backwards onto her bed over and over and over again. And once they treated, she was not psychotic, and once they treated the ulcers and the GERD, they saved a whole bunch of money because there were no more beds. right? And this poor child, and she wasn't sleeping, the family wasn't sleeping, everybody was miserable, and so this kid got better. So again, trying to really think about the behavioral cues as being cues of something else is really important. And the American Academy has a consensus statement on GI condition, and there are many different statements on clinical practice. And really the conclusions are that GI problems in kids with ASD are a real concern that should be addressed seriously. That the signs of GI problems may manifest differently in kids with ASD, and that managing them should integrate both behavioral and medical approaches, and that the association of ASD and GI and the underlying biology needs to be better understood. So the last thing I'm going to talk about is metabolic and genetic disorders. And these are things like phenylketonuria, for some of you, mitochondrial diseases. I'm not going to talk about any of these in particular. Smith-Lemli-Opitz is a problem with cholesterol, the metabolism of cholesterol. And the metabolic disorders are really, really rare, but they are highly treatable. In this country, when babies are born, they get a heel stick to find out whether they have phenylketonuria. And if those of you, the next time you drink your can of, Diet Coke or something that's not going to let you sleep, if you look, it'll say phenylketonurics, this contains phenylalanine. So individuals with PKU can't process that phenylalanine. And what happens is that if it goes untreated, these kids will look autistic, or individuals will look autistic. So it's incredibly important to understand it, to identify a metabolic disorder. I will say they are rare. So, but a comprehensive evaluation should also look for the metabolic disorders. So what difference does genetic testing make in terms of families and clinicians? Well, you can receive better guidance regarding recurrence risks from clinicians. So if you do some genetic testing and it points to something, that's important. If there's a known genetic syndrome, perhaps there are treatments that can be targeted for that. It's also important because it's helpful for the development of new treatment targets. And I know I'm skipping over a couple, but I'm really just trying to highlight the most important reasons in terms of why does genetic testing make a difference. Some families, it's like, I mean, it's not going to tell me anything, well, why should I bother? It's not covered by all insurance plans, so why should I take the extra expense? But it can be helpful. So in conclusion, here are the take-home messages. First, autism is not one disorder. I think we can all kind of pretend to agree on that. Autism is likely the result of genetic and environmental factors, and I tried to present enough evidence to support that. It affects the whole child. It really is a systems disorder. And co-occurring medical conditions can really have a significant impact on quality of life and need to be taken into consideration. Medical conditions are identifiable and treatable, and so that's also important to keep in mind. And lastly, it is not necessary for a condition to be causative for treatment to have a significant impact. So we must keep that in mind, because at the end of the day, it's about quality of life. And Christopher Reeves, may he rest in peace, he said something that forever rings true for me, and that is that we never give up on these kids. It's what I do. It's why Rich and Lisa do what they do. And it's why a lot of our clinicians and practitioners are invested in helping kids with autism, because once you choose hope, anything is possible. Thank you very much.